So the Crizotinib, this is a potent oral TKI that targets not only ROS1, but also ALK and MET. It's given at a dosage of 250 milligrams twice daily. Most of the adverse effects are grade 1-2. That means they are minor. They include vision disorders. Usually patients report light trails on the peripheral vision, some edema, diarrhea, liver enzyme elevation, sometimes constipation. So this is the study that led to the approval of Crizotinib by the FDA. This is the Profile 1001 study. It was published by Dr. Shaw and her team in 2014. And this is an expanded cohort of 53 patients with ROS1 positive non-small cell lung cancer. The response rate was 72%. Disease control rate, which means any type of response or stable disease, 90%. And a progression-free survival, that means how long did it take for the tumor to start growing again? 19 months. And I want to remind you, the slide I showed at the beginning with chemotherapy, response rate with chemotherapy, 19%, time that takes for the tumor to grow back, less than 4 months. So big improvements. In this study, the most common partner was CD74 for the fusion. And because of this, Crizotinib made it to the NCCN guidelines back in 2013, and it was approved by the FDA in March 2016, and almost at the same time by the European equivalent of FDA, the EMA. Now, like it happens in most of the molecular treatments we do nowadays, we run into resistance at some point. And for Crizotinib, there are two options. The most common one is a mutation in the ROS1 kinase domain. That happens in 60% of cases. The most common resistant mutations, G2032R and D2033N. The second type of mechanism is off-target resistant. That means a resistant mechanisms away from ROS1, and there have been descriptions of KRAS G12C or upregulation of EGFR signaling. And I know that we have an alphabet soup of letters and numbers that we are always trying to remember. So it's interesting, when I was working on these slides, I was changing the battery of one of my electronic devices, and I ran into this, 2032. So if that helps you remember, use it. What do we do after Crizotinib fails? There are several options, TKIs, either Ceritinib, Brigatinib, Lorlatinib, Entrectinib. There are reports on Cabozantinib and Repotrectinib. And you can see that the response rates in first line are very high compared to Crizotinib. There are responses with second line. But the part I want you to pay attention is which drugs have efficacy against the solvent mutations in ROS1. If you see the most common one, G2032R, most of the drugs on the left side of the chart do not work for that, including Entrectinib. There are only two medications that targets G2032R, and they are Cabozantinib and Repotrectinib. So that gives you an idea how important is what some of the previous presenters have mentioned today, that we need to biopsy at the time of progression to see what we're dealing with. Let's talk about Entrectinib. This is a multi-kinase blocker of ROS1, Entrec, and ALK. It can cross the blood-brain barrier, so has a good CNS activity. It's more potent than Crizotinib, and FDA approved its use in ROS1 fusion-positive tumors in 2019 at 600 milligrams once daily. This was approved following the pooled analysis of 3 early phase studies, the Star Trek 1, 2, and the ALCA 372. There was an efficacy population of ROS1 positive non-small cell lung cancer that were treatment naive, 53 of them. And there was a safety population that was larger with prior treatments. If you see in this study, the median age was 53, which is young for patients with lung cancer on average. They were the majority were female. The majority were either never smokers or light smokers. And CNS disease at baseline, 43%. And again, we're seeing this pattern that ROS1, ALK, some of these molecular abnormalities do go with higher incidence of CNS metastasis. The response rate was high in the 70 to 80% range. And there was a difference whether CNS disease was present at baseline or not. And if you look at the bottom of the slide, the median duration was above 2 years in patients who didn't have brain metastasis at presentation versus just a little bit above 1 year, 12.6 months in patients who had CNS disease at baseline. The intracranial responses, patients who came into the trial with stable, either treated or asymptomatic brain metastasis, the response was 55%. And the duration of response was respectable at 12.9 months. Safety-wise, most of the adverse effects were grade 1 or 2. They were reversible. You've heard these side effects with other TKIs, like lack of taste or dysgeusia was very common, fatigue, and a lot of GI side effects, as well as some liver enzyme elevation. If you look at the right side on the safety slide, grade 3, 4, those are the more severe side effects. The ones that really stand out are fatigue, 2.8%, weight gain, probably related to edema, 5.1%, and anemia. Only 3.9% of patients had to discontinue the medication because of side effects, which speaks of a good tolerance to the drug. So Entrectinib is an active ROS1 inhibitor with durable responses in patients with ROS1 positive non-small cell lung cancer, either with or without brain metastasis. There is a durable intracranial activity reported in patients with baseline CNS disease, and it's a drug that is tolerated and has a manageable safety profile.